Okay, well, welcome everyone. Thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I've been on active surveillance since 2009, and our purpose here is to educate individuals about options regarding AS, which is not a treatment, but a management plan. I'd like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. So a couple of quick housekeeping measures. We're going to hold off all questions until the last speaker. You can submit questions in the chat box, which we'll try to address after the last speaker. And at that time, you can also click the raise hand button from the bottom of the Zoom window toolbar. And if there's time, we'll try to call on you. Please keep yourself muted during the meeting. And if you mistakenly unmute yourself, we'll be happy to mute you. The speakers are presenting here today are generously donating their time, so we really want to be respectful of that. As a reminder, we are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. You also don't need to take notes. This meeting is being recorded and will be available in approximately a week from now on our website. You can also subscribe to our YouTube channel and automatically get notified when videos appear. So the last item is watching the meeting. If you'll notice in the upper right corner of your Zoom window, there's a button that says View. When you click that, you can switch between Gallery View, which is everyone, or focus on the speaker. We highly recommend selecting the speaker. So without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
Thank you, Bill. I have really been looking forward to this meeting on AI and active surveillance. This is on the leading edge of the future treatment, and it has the potential to really fold into what we're about, and that is trying to help you all to avoid overtreatment. And so I'm just very excited to have this program. And Howard, I really want to thank you too for having uncovered this and arranging to have these folks show up today. This was done on a very short-term notice, and yet we've got over 350 people registered. So, but this whole AI arena is really going to not just disrupt the active surveillance world, but it's going to disrupt the medical science world. So anyway, we have a big voice, and we need all of you. And why I say, let me just give you an example. And I've said this before, but over a year ago, the NCCN kind of made radical prostatectomies and radiation the primary focus for dealing with prostate cancer. They did not recognize active surveillance. And so we wrote to them and they changed their guidelines. And so they listened and we appreciated that. But that's how powerful your voice is. I mean, it was not our voice alone that was responsible for the NCC changing its guidelines, but I can assure you, your voice was very important. I too wanted to mention that PCRI has a webinar, a conference coming up in LA in about 2 weeks. We'll be there. We'll have a table there. But I've been there many times. I won't be there this time, but a strong recommendation for that conference. It was a PCRI where ASPI was born. It was Mark Schultz's leadership on the issue of AS that really prompted us to create this organization. And we were the first active surveillance. Well, we're probably the only real active surveillance organization in the world at this point in time. So if you're near LA, you might want to think about going to the conference. I did want to mention too that you probably recall in my case, I've been on active surveillance for 20 years, and I barely even think about prostate cancer at all. It does not affect the quality of my life at all. And part of what I speak of here is that all of you can reach a place of peaceful vigilance where you're not worried, where you're not getting a PSA and worried about a PSA or worried about an MRI. You can get there. We've gotten there. I've gotten there. Others of us have gotten there. And the other thing I wanted to mention too is that we had a founder, George, whose doctor, oncologist, is Mark Schultz, in fact. And the neat thing is that Mark and George, they're willing to push the envelope. Now, I don't think George would mind my saying this. He has a PSA of 40. Well, he's not getting intervention because he's 79. And see, these decisions about treatment and whether or not you get treatment, they're very related to age. So if you're 79, you might not be making the same decision that you made at 59 or whatever. I did too wanted to mention as well our awards program, where we have a wonderful awards program, all online now, all and why this was a special awards program was that it really kind of presented a history of prostate cancer with Mike Scott speaking, with Freddie Hamdy and Jenny speaking on the PROTECT T trial. The PROTECT, you really need to watch these awards because there's so much information there. The PROTECT T trial was really what opened the door to establishing the validity. It said you're going to basically live just as long as if you're on active surveillance as you are if you've been treated and not have the side effects that you might otherwise have. So that was a huge trial, and we gave the award for that, and the folks that were involved with that were very appreciative of receiving that award. So anyway, let me introduce my good friend Howard Walensky, and he'll introduce the speakers today.
Well, thanks, Mark. Yeah, I'm one of the co-founders of ASPI, and I'm also the editor of Active Surveillance Patients. I'm sorry, the ActiveSurveillor.com. ASPI's first medical advisor was Dr. Jerry Chodak. Back in 1994, in the New England Journal of Medicine, he suggested the idea of taking a more conservative approach to low-risk prostate cancer. And because of his efforts, other doctors picked up the challenge later in the 90s and developed what became active surveillance. Mark, a moment ago, mentioned awards, but he didn't mention that one of the awards is named after the late Dr. Chodak, and this year we gave it to Dr. Carroll from the University of California, San Francisco. And you might catch that online as well. It was very, very moving. Back when Dr. Chodak was speaking up, there was a huge increase in the incidence of prostate cancer. As some new technologies were catching on, PSA testing or screening, the biopsy gun, ultrasound. Chodak warned that prostate cancer was being overdiagnosed and overtreated. leading to many patients experiencing side effects that impacted the quality of their lives. By the end of the century, Klotz, Carter, and Carroll had developed active surveillance. Uptake was slow in the United States. In 2010, when I was diagnosed, only about 6% of us opted for surveillance. It's been growing. It's over half now, but we lag far behind Sweden and the United Kingdom. Meanwhile, in my time on AS, technology has continued to change. I was among the first to have a prostate MRI. Then came genomic and genetic testing, biomarkers, fusion biopsies, and now AI. Dr. Marks, who will be our first speaker today, will be taking on the evolution of AS. It's not your father's AS, is his title. When Dr. Marks arrived at UCLA 16 years ago, he had two goals. The first, to start an active surveillance program, and we thank you, Dr. Marks, as do over 1,000 patients who you have on active surveillance. Second, Dr. Marks wanted to improve quality of biopsies. He has succeeded at both. He has seen 5,000 patients since he joined UCLA. He also built a huge database that has resulted in development of an AI program to map prostate cancers. This can guide not only surgeons, but also radiation oncologists in offering their various treatments, including focal therapy, prostatectomies, and radiation treatment. His mapping software keeps these doctors on track, keeps them on the right trail. But he'll also explain today, I hope, how AS patients will benefit from this new technology. And there are a couple of applications that are coming. Dr. Marks is co-founder of Avenda Health, which developed the Unfold AI mapping software. Dr. Marks will be followed by Artera's medical science liaison, Mia Li-Burton, and Meghan Tierney, who is scientific director at Artera. Earlier this year, Artera released its AI prostate test, which is sparing 40 to 60% of men from the side effects of androgen deprivation therapy. And I was taking a glance as people were coming in, and I let in a guy I know from the Detroit area. We actually benefited from it. So it might be nice to have him speak up if he's up to it. Will men on AS benefit from undergoing AI testing? We'll see. And I'll turn it over to Dr. Marks, and we'll follow with the speakers from Artera. So, Dr. Marks, the floor is yours.
Thank you very much, Mark and Bill and Howard, for what you have done with this organization. I think it's extremely commendable. I think you filled a void. I congratulate you on it. And thank you for asking me to speak today. I hope this is not disappointing to you, because I think artificial intelligence is a rather small part of the evolution of active surveillance. It may be a big part in the future, but buzzwords get going in the popular parlance and sometimes get ahead of the curve in terms of the evidence. So I'm eagerly looking forward to see what the Artera people have done. Looks like we don't really compete. We kind of have different missions here, and I think there's going to be a lot more AI companies that come along. But this is very, very early. And I think for any of your listeners to go to their doctor and say, "Are you using AI?" is way premature. So I titled this talk, evolution of active surveillance, because a lot has changed since the beginning days. Subtitle is It's Not Your Father's AS. You know, this came from, let me see, how can I advance? There we are. This slogan, It's Not Your Father's, really came out of the automobile industry. This gentleman, who's the founder of the Oldsmobile company, uh, uh, his company subsequently languished, and a bunch of Madison Avenue executives got together in the late 80s and dreamed up a new form of this car, which was appeal more to younger people. And they called it It's Not Your Father's Oldsmobile, and they introduced the Cutlass Supreme, and that worked, and it turned things around. Incidentally, the slogan has stuck around a lot longer than the car. But the concept is right, because active surveillance is already more than a generation old. So this is not your father's active surveillance anymore. Just to pay tribute again, Howard scooped me on this a little bit. I've followed this story since the very beginning, and to give tribute to these three pioneers, Jerry Chodak at the University of Chicago, Jonathan Epstein and Bal Carter at Hopkins, and Laurie Klotz up in Toronto, all got the ideas about the same time. And it's really in the 90s that active surveillance became formalized as a management strategy for prostate cancer. Just a few words about the differences between then and now. In the 1990s, the buzzword was we're looking for insignificant prostate cancers. Diagnosis was made by blind biopsy, ultrasound guided only interested in 3+3s. These were the Epstein criteria, less than 50% of a core, less than 2 cores involved, generally PSA less than 10, and follow-up was at yearly blind biopsy, and the endpoint was not very well defined. Apparently, anything more than this was the endpoint. Now, it's a different ballgame. Now the term insignificant cancers has more or less disappeared. We now use risk the Gleason grading system has replaced the Gleason score, and we're talking more about GG1s and GG2s now instead of 3+3 and 3+4. Cancer core length is not been well defined, and the number of cores not well defined, because with targeted biopsies, we get longer cores and we get more of them. So this is not as important an issue as it used to be. PSA is now acceptable up to 20, especially when the prostate is large, and PSA density has largely replaced PSA. Follow-up is with MRI and MRI-guided biopsy, and the endpoint, which is pretty well agreed upon, I think, is that the appearance of any Gleason score 4+3, or now known as GG3 prostate cancer, should not be part of active surveillance because of the metastatic potential of these cancers. Let's see if I can. So my interest in active surveillance began in around 2009 when I first came back to UCLA full time. Excuse me. And since that time, we called our program ASCAP. We developed our own little logo to try to popularize this. We formed this program with some government funding and private philanthropy. We have dedicated personnel maintaining it. It's a prospective IRB approved project. We have a full-time database manager who's keeps us up to date. And our focus from the very beginning has been on prostate imaging. To date, around 1,200 men have been enrolled in this program, and the information I'm going to share with you this morning deals with the 869 men who have been followed up for as long as 12 years with MRI-guided biopsy at baseline and at least a year of follow-up with MRI follow-up. So I believe this may be the largest collection of men with MRI-guided biopsy at baseline who have been followed for any length of time. You can correct me if I'm wrong, but we were not the first to this game. You saw the pioneers, but fortuitously, when we got started with this, it was about the same time that prostate MRI and especially MRI guided biopsy became readily available around the year 2010, something like that. We assembled a team at that point at the early onset to include, and it was all focused around MR and MRI guided biopsy with a dedicated pathologist, a biomedical engineer to help me understand the technology here, a lot of technology in MRI guided biopsies, a research coordinator to keep our books, and a radiologist who became a world-class expert in MR interpretation, which is very important for any program. This team stayed together a long time. Now all of them have moved on to better jobs except me. And I'm still in the trenches here, knocking them out. The advances that I want to emphasize to you in 2024 compared to previously is that we are dealing with more and more intermediate risk men with prostate cancer. There are some provisos with this. MRI guided biopsy is very important up front because it helps stratify patients and also can be used to predict the durability of active surveillance, how long somebody can actually stay in there. You can tell that to a guy up front. Very helpful for counseling. Let's see here. We've also learned by doing lots of follow-up biopsies with MRI guidance that MRI can replace biopsy and follow-up in many cases. Not everyone needs a follow-up biopsy. Let's see here. We've learned that anxiety-driven events have decreased over time. There's several reasons for this. We can talk about this, but there was a time when people dropped out of active surveillance very quickly because of anxiety, went under radiation or surgery. That momentum has diminished. And finally, the point that I want to share with you is that focal therapy can actually extend the life of active surveillance. We've been interested in this from early on, and I will show you some data on this. First, to look at the effect of Gleason grade upon initiation of active surveillance. These are men who've had MRI-guided biopsies at baseline, right here, 0.0, and their years of follow-up. And this shows their progression-free survival on the vertical axis. This is known as a Kaplan-Meier survival curve. And we have introduced one new term. We have men, first of all, men with Gleason grade 3+4, that is the GG2s. We have men with GG1s. And we have a lot of men who've come to us with outside biopsies done by the ultrasound-guided method only without MRI, who had documented small amounts of prostate cancer where when we enroll them on MRI-guided biopsy, we can't find it again. So these are very low-risk patients. So this is a risk stratification from very low to low intermediate risk. And you can see that using this, we actually are extending active surveillance out pretty well compared to previous years. If you look just at the 5-year point, you can see that about even the highest risk patients, the low GG2s, almost 50% of them or so are still in active surveillance, have not progressed, and about 70% of GG1s are still in active surveillance, and almost 90% of those with the low risk patients are in active surveillance continuing. I want to use this same chart to show you how an MRI-guided biopsy up front allows you to predict the durability or the longevity of that person in active surveillance. This is not been well emphasized in the past, but a man who comes into active surveillance with very low risk prostate cancer has little to worry about going forward, assuming the biopsy was done properly. He does need follow-up. We do follow up with PSAs and occasional MRIs, depending. But we can predict how long that man will be in active surveillance. Look at it at 5 or 6 years. Notice the difference between these lines. Those are statistically significant. And it's helpful for a man to know his chances going forward based on his initial biopsy. I told you that MRI can replace follow-up biopsy in many cases. This is something we've discovered by doing follow-up biopsies in everybody, but when you correlate those with the MRI, what we found, and here are our three groups here. This is the GG0s, GG1s, and GG2s. And on the vertical axis is the negative predictive value. That is the ability of MRI to correctly rule out prostate cancer. And the MRI for the low risk and very low risk groups is approaches 90% or more in follow-up biopsy. For men with entering with GG2, we're more concerned, and we do want to do follow-up biopsies on them. But in the majority of men, MRI can replace biopsy in follow-up. Let's see. Anxiety-driven events have decreased over time. This is our experience beginning in year 2010 on the horizontal axis out to 2022. And in each bar, it's the number of surgeries or radiation therapies encountered by men who decided to do that despite being stable in active surveillance, that is, not having progressed. And this is a trend line showing that trend has decreased over time. Part of the reason is the accuracy of the MRI-guided biopsy and the safety that people understand that they have with very accurate biopsy. And finally, I want to show you that active surveillance can be extended by judicious use of focal therapy in these patients. This has not been well established, but I do believe this is a very important factor here. On the horizontal axis, years from focal therapy eligibility. That is the time when GG2, or if they're in surveillance in GG3, is recognized. Instead of kicking them out at GG3, enter them into an active surveillance program. On the vertical axis is the freedom from surgery or radiation therapy charted over time. And you can see the men who are undergoing focal therapy stay in active surveillance twice as long as men who do not have focal therapy. So we view the advent of GG3 in a patient in active surveillance to be a crossroad and not an endpoint necessarily, that some of these men can be salvaged for active surveillance by judicious use of focal therapy, cryotherapy, or HIFU at our place. This is a little more than I want to get into. I'm going to skip this part. The artificial intelligence tool that we have evolved over time, and there now is a company, Avenda Health, established to promote this product. This is based around our biopsy data. Each of our patients at baseline undergoes a biopsy where there is targeting of any visible MRI lesion and systematic sampling throughout the rest of the prostate. And we've done this since 2009. Anybody who has a biopsy like this can generate a lot of data, which goes into which when put together with clinical data, can be used to generate an artificial intelligence program. Keep in mind, we've done around 5,000 of these targeted biopsies over time, and each of these biopsy cores is tracked in the software of the image fusion device, so that putting all these together, we can not only identify the cancer, but we can actually use the locations of those biopsies in relationship to the MRI visible lesion to create a map, a cancer map. And this is an example of such a map where the red spot is the is the MRI visible lesion, and going out beyond the red spot shows you how far out the cancer may actually extend. We've learned that the MRI visible lesion is just the tip of an iceberg, and that almost always that cancer extends far beyond the visible area, and it may extend in fingers and not in a smooth concentric pattern. What you can generate from that is a treatment margin, and we did this primarily for focal therapy guidance to begin with, but it also is appropriate for trying to decide where to give a radiation therapy boost, if that's appropriate, or where to extend a surgical margin. And it also may have a role in active surveillance. Let me just go back one step. Hard to go back. The current challenges, as I see them in active surveillance, are increasing efforts to stratify GG2s because they're not all the same. We're looking at cancer core lengths, percent pattern 4. The advent of the PSMA scan has changed urology dramatically. We are actually doing biopsy guidance in many patients using PSMA identification of a lesion within the prostate. Current indications for PSMA are to stage prostate cancer pre-treatment or to detect recurrence, but it also has a role in looking at cancer within the prostate. This is new and going to be very important in the future. Molecular markers. There's already a fair amount of data out about the Decipher score and a number of other molecular markers, which can be used to try to predict the likelihood of a cancer from getting out of control in the future. Very appropriate for men in active surveillance. Need more data. And then I think further evaluation of the role artificial intelligence will have is also important. I think it's an exciting time to be in this work. I think that this all began around 2010 when the MRI guided biopsy became available. That is, the evolution of this became available, and the use of artificial intelligence to map cancer has many roles. In active surveillance, the size of this lesion may help predict propensity to become more aggressive in the future, and that's one thing we're measuring. There's no other way to measure the size of the cancer except by the use of this software right now. So we're very enthusiastic about that. Lots of new challenges in the future. I'll be happy to take questions, and I thank you very much for the invitation to be here today.
So Doctors Tierney and Li-Burton, the floor is yours.
Thank you so much, Bill, Howard, and Mark. My name is Mia Li-Burton. I'm a medical science liaison with the medical affairs team at Artera. And as an MSL, one of my key functions is to engage with clinicians, mainly urologists and radiation oncologists, to provide medical and scientific education on Artera's multimodal or MRI biomarkers. Hearing the stories from the clinicians about how the Artera AI Prostate Test has given them and their patients more confidence in their joint decision-making is really humbling to me. And thank you so much for inviting us. It's a pleasure to have this opportunity to introduce this test to the ASPI members today. We have come a long way in terms of risk stratification tools in prostate cancer since the 1960s, when the Gleason score system was established. Following the FDA approval of the PSA testing, the nomograms that integrate multiple clinical parameters to the rapid adoption of multi-parametric MRI. Also, the genomic classifier has been around for the past decade. And finally, in the past few years, the artificial intelligence-enabled tools have emerged. For example, Artera has developed our multimodal AI or MMAI algorithm that provide AI-enabled biomarkers to inform prognosis and one step further to predict treatment response. So by definition, artificial intelligence is a technology that enables computers to simulate human intelligence and problem-solving capacities. A couple of examples would be GPS guidance or autonomous vehicles. And machine learning is a sub-discipline of the artificial intelligence. It involves the development of artificial intelligence algorithms that use neural networks to extract features from the data and make predictions about what the data presents, just mimicking the decision-making process of human brain. When we think of AI, the examples that come to mind first are likely to be generative AI, which is designed to create some new content that mimics human-like creativity. On the left of the slide are some examples. On the other hand, the medical AI, instead of focusing on creativity, it is designed to support clinicians in diagnosing, staging, and treating disease by utilizing machine learning models to analyze high-quality data. For example, clinical trial data through a vigorous testing and validation process with the goal to improve health outcomes and patient experience. So by utilizing machine learning methods, many AI-enabled tools have further advanced the diagnosis, prognosis, and prediction of treatment response. The Artera AI Prostate Test is intended to be used after a diagnosis of localized prostate cancer has been made. It provides both prognostic biomarker and predictive biomarker results. So the prognostic biomarker results inform the disease aggressiveness of the tumor, how likely is it to grow and spread, and how likely it is to cause mortality in the future. So the Artera AI Prostate Test also provides predictive biomarker results, which informs whether a particular patient will benefit from a certain treatment. So here is a brief overview of how the test works after a localized prostate cancer diagnosis has been made. The Artera AI Prostate Test incorporates two streams of data source into its multimodal AI algorithm, one being patients' traditional clinical parameters, including age, PSA, and clinical tumor stage. The other being patients' digitized histopathology imaging data. So the MMAI algorithm deploys the machine learning algorithms to analyze the data input and provide both prognostic and predictive biomarkers. The prognostic biomarkers, we have the endpoints of 10-year risk of distant metastasis and 10-year risk of prostate cancer-specific mortality. Those two endpoints are provided to all the patients with localized prostate cancer across NCCN risk groups. And starting from August 5th, we also started providing additional active surveillance insights for patients with NCCN very low, and favorable intermediate risk patients, which Meghan will discuss in more details in the upcoming slides. We also provide a predictive biomarker results. And Bill and Howard has mentioned that we can predict whether a patient with NCCN intermediate risk disease will likely to benefit from adding short-term ADT to their radiation therapy. And this slide shows how many clinicians I've seen are using the Artera AI Prostate Test to inform treatment intensification decisions. First, the prognostic biomarker results inform the prognosis, the disease aggressiveness. If this patient has a good prognosis, then maybe treatment intensification is not necessary. However, if a patient has a poor prognosis, the predictive biomarker becomes crucial, particularly for patients with NCCN intermediate risk disease, including favorable and unfavorable. and it can guide androgen deprivation therapy intensification decision. So in the next slides, my goal is to walk you through the Artera multimodal AI algorithm and its architecture of this test. So this slide shows the architecture of the MMAI algorithm. First, patients' traditional clinical parameters are converted into a feature vector, which is a numerical representation of the data that is easier for the downstream machine learning algorithms to analyze. We then digitize patients' biopsy slide to generate digital pathology images. I wanted to point out there is no tissue consumption during this process. Everything is performed using the images of the biopsy slide. After we digitize the biopsy slide, we then segmented out all the images of the biopsy cores and pasted them together to form this image quilt. Then a digital grid was laid over on the image quilt to divide it into small patches. The small patches are the little, little squares you see here. So all the patches were then fed through this pre-trained self-supervised or unsupervised machine learning algorithm, which convert image data into numerical feature vector. Finally, those two streams of data were combined to generate an AI score, which will be used to generate prognostic and predictive biomarker results. I wanted to point out here that the self-supervised machine learning algorithm here we used, there was no pathologist labeling before we fed the patches through it. It allows the AI to learn from vast amount of raw data to discover novel patterns beyond current human understanding. And this is where the power of AI lays. Here is just an example of a biopsy core on a digitized prostate biopsy slide. And this slide shows you how the MMAI algorithm analyzes the images. First, the MMAI algorithm analyzes each patch of image to determine whether there are important tissue patterns within each patch related to the outcome of interest. As you can see, there are some, you can see on images, there are some patches are highlighted, indicating that the AI identified them as containing important patterns. And the darker the patches are, the more important they are to the outcome of interest. And you can see the AI deemed different areas, different patches as important for the prognostic biomarker and for the predictive biomarker for short-term ADT. So this is a brief overview of how the MMAI algorithm works. And this brings me to the end of my part of the presentation. I will now hand it over to Meghan, who will delve deeper into the test and the test report and the biomarkers it provides.
Great. Thanks, Mia. I think that's a really great background into the AI technology that is the core of what we do here at Artera AI. And my portion of this test is going to take us a little bit more towards what is offered in our current clinical test and what sorry, can you go back one slide, Mia?
So sorry.
No, that's okay. That's okay. So I'm hoping to walk us through what is currently offered in our clinical test and how we have come to the point of our newest edition that provides a bit more insight into active surveillance itself. And so for those of you who are again, not as familiar with the Artera AI Prostate Test, it has two primary elements, as Mia described earlier, one being our prognostic element that provides risk stratification for certain outcomes down the road, the other being our predictive model that provides information about, whether or not a patient is likely to benefit from the addition of short-term ADT to their radiation therapy. And I think the predictive element was described in quite a bit more detail back in a webinar in February, I believe, when we were last here to talk with this group. And the ASPI team does a fantastic job of making these resources available on their website. So anyone who's interested in more detail on the predictive model can go back and reference that webinar. But today I'll focus primarily on the prognostic risk stratification element of our test, because that's really what generated the new addition around active surveillance. So let's go to the next slide, which shows, again, a summary of what is used to generate our prognostic risk scores, and the combination of patient information in addition to digital images from a slide of the patient's biopsy. And that is fed into our AI algorithms, which analyze that data and output a personalized risk score that estimates long-term outcomes such as distant metastasis, or cancer spreading to other parts of the body, or prostate cancer specific mortality, which is the risk of death specifically due to the prostate cancer itself. And this particular model was built and validated using data from 5 large clinical trials, about 7,000 patients data. So really representing a wide variety of patients. And we do the initial development of the model, we lock the model, we validate the model, and that first sort of effort gives us information about how well the model itself is able to predict these outcomes, whether it is doing what we expect it to do and performing the way that we expect it to perform. But that's not necessarily where our research ends. We continue to do additional research to evaluate how the biomarker compares to other prognostic tools that exist clinically, and also to do more research to explore the generalizability of the model itself. And so I'll touch on a couple of those additional research efforts that have kind of led towards the creation of these insights for surveillance. So go to the next slide. And this shows an example of how we have compared our test to other existing tools that are clinically available. And one common tool that gives an idea of a patient's prognosis is the NCCN risk groups. And so when we have compared our Artera AI Prostate Test to the NCCN risk groupings in terms of predicting distant metastasis and prostate cancer specific mortality, we actually see that the Artera test does a better job of predicting those outcomes, which is great because now we know, how the model itself works. We know how it compares to some other existing tools. Here we're seeing that it does add value beyond just the NCCN risk group. And, it confirms that the AI is able to pull valuable and relevant information from those histopathology images to contribute to its ability to predict these outcomes. But as I said, this model was originally developed using data from 5 clinical trials. These clinical trials were primarily patients with localized prostate cancer who were using radiation therapy as part of their primary treatment for their disease. And so then that begs the question of, does the model perform similarly in patients who are using prostatectomy or patients who choose active surveillance? And so that has led to further research, which we can go to the next slide. And here on the left side of this slide describes a recent validation study that we did with an expanded cohort of patients. So here, a little over 3,300 patients who have been managed with radiation therapy or prostatectomy or active surveillance. And so we see here that in this expanded cohort of more diverse patients, our MMAI prognostic score was still significantly associated with distant metastasis. which is great because it increases our confidence in being able to use this tool across different choices for disease management or treatment. But we know that there is a lot of interest in being able to develop more prognostic tools that can really inform the active surveillance space in particular. And we run into the challenge that distant metastasis as an outcome isn't necessarily as useful for the surveillance space because so few patients with lower risk disease actually develop distant metastasis that information is not necessarily as useful. So we wanted to look at an outcome that was a bit more relevant to the active surveillance space. And if you go to the next slide, Mia, it will just refocus us to the right side of the slide here, where we highlight the outcome of adverse pathology at radical prostatectomy, or we refer to it as AP at RP for short. And what this means is that for patients who eventually go on to have a prostatectomy, and we look at the tissue from that surgery, does the patient have more aggressive features in that tissue than were present at the time of their original diagnostic biopsy, suggesting that, you know, their tissue has sort of progressed and evolved over that time. And these more aggressive features that we're looking at here are those features that would make them no longer good candidates for active surveillance. So for example, you know, progressing to a grade group 3 or higher as an example. And the way that we addressed this with our prognostic model was to take the patients who were part of that active surveillance group in the expanded cohort that we see on the left over there. And of those patients who were managed with active surveillance, 292 of them eventually came off of surveillance and had a prostatectomy. And we know we have the follow-up data for these patients. So we know of those patients which ones had adverse pathology and which ones didn't at the time of their prostatectomy. But we were able to feed their diagnostic information, so their clinical information at around the time of their diagnosis, and their image data from their original biopsy into our prognostic algorithm. The algorithm generated a risk score for those patients. And then we looked at whether that risk score was associated with whether or not a patient had adverse pathology when they had their prostatectomy. And what we found was that, yes, there was some statistically significant correlation between their MMAI risk score and whether or not they had adverse pathology. And so we're hoping that this endpoint is a little bit more relevant for the active surveillance space, can provide a little bit more information about how likely a patient's tumor is to, you know, evolve to develop more aggressive features in a shorter time window than distant metastasis. And in the next, this really provides the backbone for what has become our latest test report update, providing more insights around active surveillance. And so the next few slides will walk through what that actually looks like in translation to our test report. And so for people who haven't seen our test report before, this is a snippet of our results page, where in the box highlighted here, we see a patient's 10-year estimated risk of distant metastasis. And this has been present on our test report historically. For this patient, their MMAI risk score translates to a 1.8% risk of distant metastasis in 10 years. And that places them in the low risk bucket for our test. You have potential to be placed into a low, intermediate, or high risk of distant metastasis based on how patients' risk scores come out with our test results. And then on the next slide, you see below that our 10-year risk of estimated prostate cancer specific mortality. And so again, for this patient, their MMAI risk score translates to a 1.1% risk of prostate cancer specific mortality within 10 years. And then on the next slide, it'll highlight the right side of this snippet here. And this is what is new as of earlier this month. And this provides additional insights around active surveillance that stem from that research that I just described. And here we see we don't provide a specific percent risk of adverse pathology at prostatectomy. We are still doing work and further development to get to the point of being able to provide a sort of absolute risk of an outcome that's relevant for active surveillance. But here, our goal is to be able to provide as much information as we can as soon as possible in terms of being able to help support clinical decision-making. And so here we are, first of all, highlighting active surveillance as a potential option for patients on this first page of our test report. So hopefully being able to just trigger the question of should this patient consider active surveillance. And then we provide some more contextualization of this patient's risk compared to other patients who have chosen to be managed with active surveillance. And that comparison is based on the subgroup of patients from our validation study looking at risk of adverse pathology. So we see for this patient, their individual risk score falls within the 35th percentile of those 292 patients from our previous study. So their risk is higher than about 35% of patients and lower than about 65% of patients from this larger group who were managed with active surveillance. We also see along this blue scale, a little white bar that shows the distinction between the number of patients in that larger cohort who would fall within the low risk category on the distant metastasis on the left hand side of the snippet, and the other 21% of patients would fall into our intermediate risk. And so it also provides a little bit more of a comparison for how this patient compares, again, to this broader cohort of patients who have been managed with active surveillance. And so again, hoping that this can provide a little bit more information that can support decision-making around active surveillance for patients who are newly diagnosed and thinking about what is the best way forward for me. And can use this information in combination with all of the other information that your doctor has available and can bring into that discussion, but that this can be one piece of that can hopefully be helpful. And then I think we have one more slide. Oh, yeah, I was gonna skip over these predictive biomarker pieces. Again, so what we wrapped up with the active surveillance insights is all part of our prognostic element of our test. It's been brought up a couple of times, as I said, that we do have this alternate predictive biomarker as well that provides information about whether or not a patient is likely to receive benefit from adding androgen deprivation therapy to their radiation therapy. And this particular result is only provided to patients who fall into the NCCN intermediate risk disease group, because those are the patients who are most likely to be making these types of decisions. And this has been really well received. And I think Howard mentioned, that there are some patients in this group who have used this test and potentially benefited from this test. In our validation study, our model identified that really only like 32% of patients were classified as biomarker positive and likely to benefit from using ADT. So there's quite a few patients who could be spared the side effects of ADT if their tumor is not as likely to respond to that particular treatment. And then one more slide. Yeah, perfect. So this helps to give a visualization of how our results are provided based on patients' NCCN risk groups. So, here in the US, NCCN really provides the the core of our standard of care. And so we want to provide our tests in a way that aligns with that standard of care. And so patients across all NCCN risk groups will receive our prognostic information about risk of distant metastasis and risk of prostate cancer specific mortality. Patients who are candidates for active surveillance, according to NCCN, so very low, or favorable intermediate patients will receive those active surveillance insights. And then, as I mentioned, the predictive results around ST-ADT are provided for patients who have NCCN intermediate risk disease. And so I think that wraps up our presentation for today, and we can probably hand it back over to open up for questions.
Well, appreciate your presentation, and we will open up for questions for all the doctors above. And you know, I had a question for Mia and Meghan. Dr. Marks expressed some caution about AI in general. And you know, I think we all would want to stay away from overhyping. So maybe this is a question for the three speakers, or two of them, or one of them. You know, where do we stand now with AI? Is this still a period of caution? Is some of it okay? Is none of it okay? Dr. Marks, do you have any thoughts on that?
Well, I think it's great. I commend the Artera people. I think it's really interesting what they've done. I think they've taken older concepts and really modernized them tremendously. I have to think back to the Parton tables and the Capra scoring system. What they've done is to take those scoring systems and put them on steroids with a lot more data. I think it's great. I think we just have to wait and see how the data shake out. I mean, this is a very interesting time in medical history for the incorporation of AI. This is like the beginning of automobiles in the early part of the 20th century. We're going from cart and buggy to horses. It's all about the data. And the problem with AI in general is that it's a black box. It's very hard for others to duplicate. That's true with our system. That's true with their system. They have their own algorithms that make this work. So I think we just have to see how it plays out. Looks interesting.
Yeah, Mia, Meghan, do you have any response specifically or generally to?
Yeah.
Go ahead.
Yeah, I was just going to say, I think Dr. Marks makes really good points that, AI is really growing rapidly in the medical space and more broadly as well. I will say that, our Artera's test is part of the NCCN guidelines. So there is some kind of confirmation there in terms of the level of evidence that is supporting our AI and the kind of amount of continual research that we do. We try to be very rigorous in our approach to developing AI. We work with a lot of institutions, a lot of physicians as we are developing our products to try and come up with things that are scientifically sound as well as like clinically useful. And I think we're also seeing a lot of changes in the regulatory space around AI, and so I think that will also be something that all of us who are working in this space will be navigating in the years to come.
Yeah. Now, Dr. Marks, we've gotten a lot of questions about focal therapy, and maybe Jeff in the background is looking through the questions and can bring some up. But I have a question for you. To be a purist about active surveillance, I take it to mean you haven't been treated. The focal therapy, and it comes in a variety of flavors, is a treatment. So I'm wondering, technically speaking, to be a stickler, would you still, after you treat somebody with focal therapy, are they, can they, really be considered on active surveillance? And what do other doctors think about that? Or am I just being too much of a stickler?
Well, you're a Puritanism. I mean, this is you're looking at it from a puristic standpoint. What we do is when somebody has a focal therapy intervention, we follow them exactly as we would as if they were in active surveillance. It's like starting the clock over again with them. And we build in follow-up biopsies and follow-up MRIs in all our patients on active surveillance who get focal therapy as part of their active surveillance regimen. But patients welcome this. After all, the motivation is to avoid surgery or radiation therapy. And if they can do that with something that is not going to change their quality of life and allow this tumor in them to be observed going forward instead of treated radically, they welcome it. And we have our patients are very enthusiastic about this when it's appropriate.
And by the way, I mean, there is a lot of debate about focal therapy. Maybe you can define for us what focal therapy is and what it isn't, and who is a candidate for focal therapy. In other words, we had another program earlier where we had a speaker, Dan Spratt, who's a radiation oncologist, and he said that focal therapy is being oversold to some patients with Gleason 6. And so do you feel like Gleason 6 patients, maybe high volume Gleason 6 patients, are candidates, or how, what's the reality for this?
So those are great questions. Number one, we do not treat Gleason 6 with focal therapy. Even high volume Gleason 6, we continue to watch and follow with additional biopsy and MRI going down the road. A candidate for focal therapy is someone who has less than half of a lobe involved with prostate cancer of usually Gleason 3+4, some with 4+3. And that is, I think most people would agree with that. 4+3 is a little more toward metastatic disease. So focal 4+3s have to be watched a little more carefully. That is GG3s than the GG2s. But we deem both of them to be appropriate candidates. Now, there's a lot of anatomic information that goes into the selection process, because if you've got the 200 cc prostate and 100 cc's of it is occupied by cancer, probably not a good focal therapy candidate. A lot of these things, these questions have not been answered in a formalistic way yet. But in general, half of a lobe or less, and we're using cryotherapy and HIFU. HIFU particularly is very good for targeting posterior lesions in smaller prostates. Cryotherapy more for anterior lesions in larger prostates. Or there are several other methods of focal therapy which we don't have as much experience with. But when they get followed in clinical trials, and all of our patients are in what we call open label clinical trials, they've all signed consent. These are in NCT registered trials. Patients embrace this, and we like it.
Howard, if I could jump in here for a second, there's a few questions that are directed directly to Artera, and I'd like to give them a chance to answer some of them.
Go ahead.
I can jump in on, I think there's a couple that are more related to our the research and our background of our model, and I can maybe take a stab at those first and then hand over to Michael or Mia for some of the more logistical questions. So I see one that asks about whether we have repeat MMAI determination for AS patients and whether our MMAI is stable over time. And currently our product has been validated to use the earliest biopsies for patients. in terms of predicting outcomes. We have internally looked at whether the scores change if we look at, you know, serial biopsies over time versus just the first biopsy, and we have not seen a significant difference in the predictions, whether we use just the first biopsy versus, you know, all biopsies or their most recent biopsy. But technically our product is validated for using the original diagnostic biopsy. And then I think there was a question around Gleason grading. And when we were originally developing this model, we initially had included Gleason score as an input to the model, in addition to age and PSA and T-stage. We were able to remove that because we believe that the AI imaging is actually able to pick up on some of those Gleason features when it's looking at the images of the tissue sample itself. And so that we might be able to pull that information about Gleason from the digital images as opposed to using that as a clinical input, like from a pathologist's reading. And so with those, maybe I'll hand over to Mia and or Michael to talk about general cost.
Yeah, I already answered the question in the channel, but basically the Artera AI Prostate Test does have a Medicare payment rate. So for any patients that are on that have Medicare coverage, there should not be any type of out-of-pocket cost for the patients. For commercial payers, we do submit a bill to the insurance companies for the cost of the test. Our list price is $1,420. But we will certainly work with the patient. We do have a financial assistance program. We understand that, you know, this can be a financial burden for patients, and our goal is to obviously make this widely available. So we will certainly work with the patients and with the insurance companies on the commercial side and try to figure out a path forward to make this test available.
Hi, Bill. I'm going to jump in here. I've seen a lot of questions. Thank you, everybody who's participating. There's mention of biomarkers. I think the panel, it would be good. Perhaps Dr. Marks could lead us into a discussion, the definition of what is technically a biomarker. My understanding, it's a scientific fact about your body, something that's been tested and shown to exist in you. For example, PSA, for example, some of the tests, there are several tests. So first with the biomarkers, and then secondly, how does the artificial intelligence model that we're seeing today, Artera, compare to some of the other biomarkers and particularly some of the other tests? Some of the questions have mentioned Decipher, Polaris, and others. And then perhaps capping that is going back to my first day at the University of California, Berkeley, a shout out to Dr. Marks, go Bears. A certain amount of information goes into modeling, affecting the information that comes out. I would like the presenters to be fair about describing the limitations, perhaps, that have in this model versus the results. Thank you.
I'm happy to take partial of the questions. So currently, there's no head-to-head comparison data between Artera AI Prostate Test and other genomic-based tests. So we wanted to, there are two tests that are looking at different perspectives of the disease, and genomic tests, of course, they're looking at gene expressions. And the Artera AI Prostate Test, we are looking at the histopathology imagings and are more like a morphological changes of the prostate tissue. So another difference is for Artera AI Prostate Test, like I was presenting in the presentation, there was no tissue consumption. We're using the slide of the biopsy. So there are some difference between those two tests two types of tests, and the goal of the test is to provide additional information in addition to the clinical parameters. So, but in summary, we do not had to have comparison. And
Let's ask Dr. Marks. Dr. Marks, can you lead us into this broader discussion?
So for a biomarker, broadly speaking, is it an indirect measure of something that you want information about? The Artera people have identified theirs as a biomarker, and so actually the Avenda people have also called their cancer map a biomarker. And fine, that's fair if that's how they want to do it. I think that's a fair way to state things. My personal feeling is that one day the genomics will replace everything, but we are not anywhere near there yet. I think Artera has a very interesting platform that will allow for later probable incorporation of additional information that becomes available, like the genetic materials or perhaps imaging, which I notice is also not part of their system. But it's all about the black box and the algorithm that the AI scientists have chosen to use for their product. And could there be a competing product to the cancer map? Sure. And could there be a competing product to the Artera? Sure. It's just a matter of getting the data. I think they've done something very clever in using existing prospective clinical trial material to prove the worth of their product. I thought that was very clever, and I look forward to using it. I'd like to ask, how does a doctor get to order this test?
Yeah, I can take that. It's actually quite simple. The doctors can reach out to and actually anyone. And I know there's a lot of questions on this call. Please feel free to email support@artera.ai. I'll drop that into the chat as well, so you guys can just click on it. But yeah, please send all inquiries. If you're a clinician, we'll be happy to set you up. Unfortunately, Dr. Marks, since you're in California, I think we're not available there, so I don't want to get your hopes up there. But would certainly love to chat with you and talk to you as we do hope to get California certification in the coming months. But for all other inquiries, please direct them to support@artera.ai.
Basically, the doctor or the hospital mails you the slides, and the clinical information.
Yeah, basically, yeah. We will reach out to the pathology labs to get the samples mailed out to us to our lab, our CLIA lab in Florida. We'll scan the image, we'll scan the biopsy slides and return the slides back to the pathology lab, and that's how we run the test.
I can interject something here. I had written a couple of stories about this, and the Artera people can tell me if I'm wrong, but the goal with this, Dr. Marks, is eventually you won't have to send slides, you just send the image. Am I right or wrong?
Yeah, that's what we're working towards too. It's currently right now. Oh, sorry, it looks like there's some background. Yes, currently we do need the slides to be sent to our lab in Florida, but we are working and Meghan kind of mentioned this earlier, the regulatory path forward. This is sort of a new thing that we're working on with the FDA to make sure that the slides being sent or images being sent from all sorts of different scanners, from different path labs, etc., is going to be sufficient quality and all that type of stuff for us to be able to use. So those are ongoing discussions, but that is certainly the direction that we're hoping to be able to achieve.
Does your algorithm differentiate between targeted biopsies and systematic biopsies?
Meghan, I'll let you answer that one.
Not currently, no. We accept any sort of biopsy tissue. We request that it represents the highest grade tumor from the particular biopsy. But it is in our research pathway, I believe, projects to kind of look at whether we see differences depending on kind of the ultimate source of that biopsy.
Yeah. I need to interject. We're almost at the time we said we would stop. But I'm sure, if any of the speakers would stick around, that people still would like to have their questions answered. So,
Howard, let me jump in here. Here's a good question from Greg.
wait a minute.
happened-
Wait a
Oh,
minute.
okay.
We have to determine if our speakers can stick around, Jeff, before we jump in.
Okay.
So, Dr. Marks, can you hang in for a little while?
This is fun. Let's
All right. Okay, and I'm going to assume the Artera people feel the same. So why don't we go for a little while and see what happens?
Okay, thank you.
Go ahead.
Thank you for the clarification. Classic case, a little dueling here. What happens if the clinician, his gut feeling or his knowledge base differs from the Artera report or any artificial intelligence report? Ethically and clinically, what happens?
Yeah, I think that's a really good question. And I can just speak quickly from the Artera side on that. I think we tend to view our test as, one tool that's available for clinicians and patients to look at. We provide, piece of information based on, what our test is able to offer. That is one piece of a picture. Patients in general are much more complex than I think anything that one test can pick up on. And so, we tend to position our test as something that can hopefully provide some additional information, but should be looked at kind of within the totality of a picture of a given patient and their particular preferences and goals.
I'd like to get back to some of the focal therapy stuff. Dr. Marks, we were talking about the puritanical view, but let me ask you this. Presumably with whatever treatment that you're doing, you are removing any Gleason 7s. So does that sort of set the clock back, and these patients potentially are Gleason 6 patients, and so they qualify for active surveillance? Is that a way to look at it?
Yes, that is a fair way to look at it. If, for example, if a patient has Gleason 7 on one side and a random spot of Gleason 6 on the other side, we tend not to worry about that other side with the Gleason 6, and it would not be treated, and it would be followed. The trouble with prostate cancer is you need long follow-ups to really know anything about it, and that's why a new drug for lung cancer is going to have an answer very quickly because the mortality rate is so high. A new treatment for prostate cancer is going to take a lot longer to determine its real value. Interesting, the PSA test, for example, now dates back to the early 70s, and it's still extremely valuable. But there aren't many other things that have that degree of history and proven value. So we just have to wait and see, and to be sure that we have good long-term trials designed, and organizations like yours are so important in getting people to enroll in these long-term follow-up trials. Active surveillance we are accumulating lots of long-term follow-up for active surveillance. As I think it was Mark who said he is a 20-year survivor in active surveillance. We don't have any 20-year focal therapy people, but we have some 10 years, and we're getting to learn more and more about it. It's something that fills a niche in our armamentarium between active surveillance alone and radical treatment.
Mark Perlow brought up a question. Well, he points out that European guidelines suggest focal therapy should be limited to clinical trials. He asks if that should be adopted in the U.S., but I'm pretty sure the American Urological Association recommends that any patients going on focal therapy be included in trials. And I think you said all of your patients are enrolled in trials. Am I getting that right?
Yes, That's correct.
Okay.
Oh. Howard, we've got a couple people who have had their hands up for a while. I think it'd be good to, give them a quick shot at it.
Yeah.
Robert,
Mike Wynn, his arm must be falling off by this point, so maybe Mike.
Hi, this is Michael Wynn in Denver. I'm a former professor of engineering, so I got a couple of questions, one for Dr. Marks and the second one for the AI team. The first question, Dr. Marks, is through several of the informal conversation I have with various different urologists, they think that the location of your tumor is fairly important. If your tumor is in the transitional zone, it tends to be less, the progressions of that will be less risky compared to if you had a tumor in peripheral zone. So that's my question, Dr. Marks. The second part for the AI focus is that I work with both machine learning and deep learning. One problem we run into is that essentially there's no real good way to query the system to ask it, how did it come up with that particular prediction? Can you give us a little more, explanation of how you do that?
Now, let me take the second question first. I want to be sure I understand. You're talking about the Unfold AI prostate mapping. Is that what you're talking about?
No, I'm talking pretty much essentially, you got the black box. You got, Bayesian, algorithm and so on and so forth. These are black box for machine learning or for deep learning. If you feed data to that, it come up with some prediction value. You cannot really ask the system, how did you come up with that particular, result? I mean, very difficult to do that because of black box. I think you mentioned that in one of your conversations.
Yeah. I don't know how to answer that question, frankly. I think somebody else will come up with a little different algorithm, a different black box, and the answers may be different. And that's what makes the world go around. But I think with regard to your question about transition zone versus peripheral zone cancers, I think yes, you see, across the board, about 70% of cancers are found in the peripheral zone, either posteriorly or in the anterior horns as it sweeps up. But I would be more in, I believe more in the Gleason score or the genomic predictors, or possibly the Artera predictor of going forward. But I think it would be hard to ignore a Gleason 8 prostate cancer in the transition zone.
Thank you.
Okay, Robert Wood, you've had your hand up for quite a while. How do you chime in?
How are we with metal hips to be confident in multi-parametric MRIs in terms of getting a accurate PIRAD score?
So this comes up in my practice every day. And the answer is it depends how old that metal hip is. Because if it was put in 20 years ago, it may not be MRI compatible. If it was put in with the past 5 or 10 years, it probably is titanium and is MRI compatible. Frequently, the radiologist will review the device with the manufacturer, determine what can be done, and turning the magnet down from 3 Tesla to 1.5 Tesla typically gives good results. We have many examples of that. There's a lot more that goes into the value of an MRI than just the Tesla. But we do lots of 1.5 Teslas in people with artificial hips.
Thank you.
Okay, Mr. Hunter, would you like to ask your question?
We should note he's calling us from Scotland. So welcome.
Thanks very much. Yes, thank you for this. It's all a little bit over my head. Dr. Marks, if I could take you back to very basics. You mentioned at one point PSA density was more applicable now than PSA, and yet later on you went on and said PSA is an extremely good marker. I've been on AS since mid-21. In January 22, my PSA density was 0.24, and in January 23, my PSA density is 0.36, which is seems way above what is acceptable, and yet my PSA is 8, and my consultant doesn't seem too worried. Can you just clarify my PSA density has never been as low as it should be, I don't think.
That's interesting. I would assume you have a rather small prostate. If I were you, I would ask them what your percent free PSA is. That's another modifier to help determine, to shift this toward benign or malignant etiology for the PSA. Across the board, prostate volume is the main determinant of serum PSA levels. It's a direct linear relationship between prostate volume and serum PSA levels. Big prostate, high level; small prostate, low level in general. And when it escapes those boundaries, that's when we get concerned. But a PSA density of 3 is remarkable. That's very high.
No, 0.3, sorry, 0.36. It went up, it was 0.24 to 0.36.
Yes, that's a very high number.
My prostate volume is 21 in beginning of 23.
Have you had an MRI?
Yeah, and they don't really see anything when they look at the MRI. Twice now, they said, oh, there's really nothing to see. It may not be a malignancy, but I mean, I've had the biopsies. And
so then you got to think of other things, like, do you have a family history of prostate cancer?
Yes.
So if you were my patient, I would biopsy this regardless. Another consideration is a PSMA scan, if you can get the healthcare system to pay for it. Yeah. PSMA finds cancers that MRI do not find. So that's an idea.
Yeah. But 0.36 PSA-D you would be concerned about.
Absolutely. 0.15 is the normal cut point.
Thank you. I won't take your time anymore. Much obliged, sir. Thank you.
How about David Peterson?
I had a PSMA PET test scan and everything. I want to know if Artera can use that information instead of a biopsy. I haven't had a biopsy in order to do their test. And if not, are there any other medical AI firms that anyone knows of that can take PSMA PET scan information and use that to determine whether, what I'm most concerned about is whether I need hormone therapy. They've suggested radiology, but I'm concerned about PET hormone therapy. I have general, some metastasis, but very little. Thank you.
Yeah, I can say Artera has focused our technology primarily on the use of digital histopathology currently, so we don't have the capability to incorporate a PSMA PET scan information into our algorithms at the moment. But I'm guessing Dr. Marks can probably speak better to potential options on the imaging side of things.
Did you say you had metastases?
Yes, a little one gland right adjacent to the prostate.
So this describes a new area of endeavor for urologists and radiation therapists today. This is called the oligometastatic situation. You definitely should have a biopsy. It will be helpful in directing your therapy, which may include that lymph node. I'm happy you don't have any bony metastases. That's a good finding on this. You should ask what the SUV maximum score of that PSMA uptake is, because and that stands for standardized uptake value. If your PSMA score, the SUV score, is more than about 10 or 12, that is certainly a cancer and probably a high grade malignancy. But the biopsy can give lots of information. It can also give information about treatment regarding drug therapy. If there's that's what the Decipher score is all about, and other these tests looking for genetic mutations that may be treatable. There's a whole new class of drugs aimed at this. So don't be afraid of the biopsy. It may help save your life or prolong your life.
Well, if he gets the biopsy, he can turn it over to Artera also, which would provide some direction on ADT. So,
Howard, I have to sign off. Great being with you.
Okay. Well, thanks
Well,
for
thank you so much for that, and very fascinating webinar today.
any remaining questions for Artera. Jeff,
I have one, if I may.
Yeah.
Classic case. My wife is in the art world, and a lot of artists post their images online. And some of these images are being used, you might say, without permission. To the question, we have a number of biomarkers and a number of tests that are obviously patented or otherwise private property in the use of the legal terms. This is a futuristic question, but how will the AI world be able to generate more complete information by getting competitors, if you will, to coalesce so that the AI algorithms are more powerful?
I think it's a really interesting question, a very good question, and I think one that is probably on a lot of people's minds these days, as we see these different capabilities in the AI space popping up, in different areas, even within just medical AI. I think everybody at the moment is aiming on trying to develop in a particular area, right, where we can have a certain amount of expertise and develop really good models that focus on kind of a specific aspect of medical care. And I think it will be interesting to see in the future, as we continue to grow our capabilities in the AI space, where there are opportunities that arise for connection between these different technologies.
Well,
we have a hand up. Howard, there's Hans.
Yeah, I was going to make a point to you, Jeff, on your question. Similar kind of thing is involved with the genomic testing and with the biomarkers. And a lot of the companies have been reluctant to have bake-offs or cook-offs to compare their products because they could get bad news that way. So I don't know if it's going to be as easy to happen as Megan suggested. There's a lot of proprietary information there, and people are protecting their patents.
Or something like the NCCN perhaps would be in a better position, some of the broader neutrality, if you will.
Yeah, now we're going to call on Hans.
My question was, could the Artera test be utilized in cases where the MRI does not show a lesion? I've been told, oh, it's too small. We found it in the biopsy, but it's evidently too small, and that went on a bunch of years. So I don't know whether if it can't be a guided biopsy, then is it in play or not? Thank you.
Yeah, I would say we don't currently specify parameters for the type of biopsy that's done. But if there is prostate cancer that can be detected on the biopsy slides or in the biopsy specimen, then it should be able to be submitted for the Artera test.
I will add a little bit to Megan's answer. So once your physician places order, after your pathologist mailed the slide with the highest Gleason score to our CLIA lab, we'll have our in-house pathologist to look at the slide again to make sure the tumor is present, and we'll proceed with the order to analyze the slide as long as there's tumor on the slide.
So any idea how many years those slides stay good? Because mine were from like 10 or 12 years ago.
A lot of the trials in our validation and development model were from the early 19s. So, and we have a quite high success rate of reading the slide and process the data.
Thank you.
But then you run into how long does the person who has custody of your slides holds onto it? My experience was that after 5 years, they may get rid of your slide. So You know, I don't know if Megan or Mia know about the rules on that.
Well, this was Hopkins, so I think that they probably still have them.
Gotcha. Well, sounds good. Mike Wynn again.
Yeah, I'd like to go to and ask the Artera folks second questions. I know you guys been around for the last 2 years, I believe, right? And so I know that toward the end of your presentation, you talk about, you know, how you validate the data and so on and so forth. And you talked about predictive value for 10 years. So how do you do currently your process of so-called ground truth verification to make sure that you're predicting, you know, a result, a report kind of map into something that you 10 years from now could be still valid?
I think that's a good question, and also kind of I think echoes Jeff's question from earlier about potential limitations to this process. And you know, we have worked primarily with you know, large historical prospective clinical trials because they have the amount of follow-up time that we need in order to look at these 10-year outcomes. But that means that, you know, sometimes during that time, you know, treatment standards of care may have changed, treatment approaches may have changed. You know, we do advance in technology and care practices over time. And so it is, you know, on our minds and as part of our, you know, continual development of our products to make sure that we are staying connected and bringing in as you know, current of data as we can, you know, in order that so we're not just developing a test and letting it sit, right? We develop a test and then we continue to try and optimize that test over time using more contemporary data so that we make sure that we are tracking that biomarker is working sufficiently, you know, as we progress forward in the future.
In one of the presentation of different group, they mentioned that you guys consider to be by the FDA a level 1 evidence type of platform. So I assuming that, you know, Artera AI test is FDA approved. Am I correct?
So the Artera AI Prostate Test is the laboratory developed test. Just as other genomic-based tests on the market, we are not FDA approved. And it is just the nature of this type of test. It is not required to be approved by FDA.
Thank you.
Eric Milson asks, can one volunteer their slides to help the AI learn and increase accuracy? So are you looking for volunteers so that in Artera?
That's a fantastic question. Thank you for that, Eric. We don't have a process currently for individuals to donate their slides to help with our research, but I will say we work with a lot of data from institutions, clinical trials, or just medical institutions who conduct research and develop databases at their sites. And so we oftentimes will collaborate with those sites to leverage the data that they have developed. And so I would say, you know, a great place to start would be, you know, reaching out to your doctor and seeing if there are opportunities for you to contribute, you know, your information for research purposes, if you're interested in that. Yeah, thanks.
Okay. Jeff or Bill, do you see any other promising questions? Anybody else want to raise their hand?
Well, there have been a few more questions, but we're getting real close to the 2-hour mark here. So our guests been more than accommodating in that capacity. We may need to wrap it up.
Yeah, I think that's a good suggestion, Bill. This has been fascinating, and my cup runneth over. I'll say that this has been one of the best webinars that we've had. I too, for the active surveillance pioneers that are on the call, still we at ASPI are always in need of your support. We're always in need of volunteers to edit, to help us with fundraising and lots of different opportunities. And Bill is our executive director, and please get in touch with us. And please too, if you go to PCRI this year in LA, stop in and see us at the booth. We'd love to meet up with you face to face. So thank you, Mia and Megan, and all of you who participated.
Thanks again for everything you've done and all your time. And the video will be available in roughly about a week, and everyone will get a notice to that effect. And I'm sure it's going to be very well watched.
Well, thank you. We really appreciate the opportunity to come and chat with you. And it's been a fantastic discussion. Thank you all for all the work that you're doing in the active surveillance space.
Well, thanks, Megan, Mia, and let's not forget the third M, Michael.
Oh, yes, Michael. Thank you, Michael.